This is Tim Miller, Lima's Global Business Unit Manager for ProMade, the design and 3D printing service for complex orthopedic solutions. I'd like to welcome you to episode 3 of Lima's complex glenoid reconstruction series. When off-the-shelf implants cannot meet a patient's needs, patient-specific bespoke solutions. In episode 1 and 2, you've heard about the use of grafting and off-the-shelf augmented glenoid implants for complex glenoid reconstructions. The surgeons have spoken about the pros and cons of both, and more specifically, the limitations of each. For example, the need to have an adequate amount of the central peg and host glenoid bone for a grafting case, or enough bone for peripheral support and central peg stability in an off-the-shelf augmented glenoid. But what if there is not adequate glenoid bone for the central porous peg? Or, in order to prepare the glenoid for an off-the-shelf augmented glenoid, you would need to remove too much glenoid bone to make it fit a multiplanar deformity, possibly resulting in medialization of the glenoid. In these cases, you may need to look for alternatives to provide you with the confidence in primary stability or ways to augment long-term fixation versus depending just on screws. In these patient-specific bespoke solutions, they can be customized to match each patient's needs. For example, adding coracoid and acromial supports for primary stability, or more bone porous surface contact for more biologic integration to enhance long-term load transfer and implant longevity. Our first speaker on these patient-specific bespoke solutions is Dr. Martin Petermann from Leipzig, Germany. He'll be covering his experience with these custom solutions and some of his research looking at the accuracy of the custom surgical plan to actual achieved placements.
My name is Martin Petermann. I live in the beautiful city of Leipzig, Germany. I am a shoulder surgeon, and throughout the year I am dealing with multiple cases with severe glenoid bone deficiencies. And those cases are pretty much always unique. I started to work with Lima in 2019. And back then, I also started using patient-specific implants as an option to treat those unique and mostly challenging cases. And after I overcame the first anxiety of the unknown, I realized that with this technology, it holds a huge potential. So it's a pleasure for me to talk about this topic here. There are multiple causes for glenoid bone defects, as listed here. And I would like to emphasize on the last one, failure of implants, because unfortunately, they often lead to very severe deficiencies. Like it can be seen, for example, on the right figure, where a base plate of a reverse shoulder arthroplasty has broken out. And every surgeon that has experienced one of those cases knows that usually there is not much of the glenoid left. Here's another example of a total shoulder arthroplasty like it was presented to me 12 years after implantation. The polyethylene glenoid has loosened and the osteolysis has completely destroyed the bony glenoid. And just to focus a little bit more on this issue, it has been well investigated that glenoid failure is a major cause for reintervention for all total shoulder, reverse shoulder, and hemiarthroplasty. Together with the fact that worldwide the implantation counts for shoulder arthroplasty rise, potentially there will be even more of those difficult cases in the future, which emphasizes the need for very sufficient treatment strategies. So I was asking myself, what can I do besides choosing the right implant to achieve a good outcome of a total shoulder surgery? And I think two of the main issues that are very important for the success are first, primary stability, and second, proper positioning. Primary stability is mandatory. For the surgeon, it is just a subjective stable or unstable, because intraoperatively, no one tests out the forces that are necessary to break out a well-fixed implant. So you have to very much rely on the implant itself and its fixation capabilities. Of course, all in relation to the according bony situation. And second, not only being able to achieve a good and stable fixation, but to position the glenoid implant correctly is also very important, as it has been shown that malpositioning is associated with inferior results and possibly premature failure. Mostly the three main degrees of freedom, version, inclination, and mediolateral offset, which means restoration of the glenoid joint line, are taken as a reference for glenoid implant positioning. And there are cases like this, you have to come to a choice that are unique and at least that are not very easy to handle. And I think it all depends on the severity of the bony defect. But for the severe or even disastrous cases, it can be crucial to choose the right option to achieve the aforementioned goals intraoperatively. Of course, glenoid bone grafting is an option, but it is technically demanding. There are harvesting issues, and you have the risk of resorption with secondary instability. And also, implantation accuracy decreases with increasing defect severity, which is common sense in my opinion. Standard revision implants may also be used. They have the disadvantage though that usually further bone needs to be removed during preparation in order for the implant to fit, and weakening this way the already deficient bone further. And this may be crucial for the fixation. Patient-specific implants, on the other side, have the big advantage that irregular surfaces, like they naturally occur, can be addressed. Usually, that no further bone removal is necessary, and a larger bone contact error may result in a more stable fixation, intrinsic, if you will. At this point, I would like to show now an example of a 50-year-old male that I treated and monitored for some time. He showed up 1 year after implantation of a total shoulder arthroplasty, like on the left figure seen. He had persistent pain and decreased range of motion. After some time, it became clear that the arthroplasty was infected. His shoulder needed to be removed, and he had multiple revision surgeries, including a cement spacer. And on the right figure, the CT scan before implantation of a reverse shoulder arthroplasty showed a significant glenoid bone defect. Because I didn't want to compromise on anything, I uploaded the CT scan in order to plan a patient-specific implant. As a result, this case report was created. And it may be a little bit confusing at first sight, but it covers up all relevant issues of the surgery and the clinical case. This is the surgery before the surgery. It makes your medical life easier if you are able to be aware of all pitfalls and to visualize certain details before the surgery. That is the three-dimensional visualization of the implant planned for the patient, as it would be positioned on the remnants of the glenoid. And you can play around, and as you do so, you can see the very irregular surface, so the implant itself augments the bone defect. And when you look at the thickness of the implant, I think reaming down would have been a bad solution. And after the surgery, this is the post-operative X-ray, which shows a proper positioning. The post-operative CT scan shows even more details on implantation accuracy and realization of the preoperative plan. And this is the clinical result 3 months post-operative. Unfortunately, the patient had a car accident riding his bike 2 weeks after he was discharged from the hospital. He suffered a pelvic fracture and calcaneus fractures on both sides, making it a little bit hard to stand up. So he had a lot of problems, but at this time, his shoulder was his least. What does the literature tell about patient-specific shoulder implants? There exist only a few recent studies of modern custom-made glenoid implants with short-term follow-up. I summarized this in a German publication, which I would like to share here, and I think the results are more or less internationally readable. They all show a significant functional improvement and no loosening 2 years after surgery. The complication rate is moderate, but you have to keep in mind that sometimes difficult situations of the patients that have had multiple surgeries before play a role. And so I think the complication rate is distinctive and comparable. We also conducted an investigation about implant accuracy of custom-made glenoid implants. The preoperative plan was compared to the postoperative by CT scan determined implant position. And as a result, we got those overlapping implants that can be evaluated in 6 degrees of freedom. By the way, this is the implant of the patient a couple of slides ago. And this is the data. This is part of a publication that has been submitted to a JSES affiliated journal and is being reviewed right now. It shows that statistically all measurements, but most importantly, version, inclination, and mediolateral offset can be realized with a good precision according to the preoperative plan with this technology. And to have a differentiated look on this topic, there are some issues that are yet unclear and have not yet been examined sufficiently. The implants may result in a big metallic lateralization, which leads to an altered transmission of force to the bone compared to standard shoulder arthroplasty. And that may be a potential risk. And very oddly, the advantage of achieving a very stable fixation may be also a disadvantage when it needs to be revised or at worst removed. Also, the bone implant interface could be very medial, making it harder to reach. Monetary issues are still, at least in my country, a topic for discussion. And of course, there is no long-term clinical data to finally assess this technology. And as I come to the end of this talk, I would like to summarize. Patient-specific glenoid implants are a new option for treating glenoid bone deficiencies. With this technology, you are able to achieve a primary stability as well as an accurate positioning of the implant at the same time. The existing short-term data is very promising, but of course, further research is necessary. And to exaggerate a little bit at the end, perhaps, and maybe just perhaps in a few years, we speak about patient-specific implants as being a game changer in treating glenoid bone deficiencies. Having said that, I thank you for your honorable attention and I thank Lima for the opportunity to speak here.